Today we'll be discussing about high altitude sickness. It's important to know about the high altitude sickness because about 1/5 of the Earth's surface is covered by mountain, and every year a large number of people go to high altitude and mountains and they suffer from the altitude sickness. People go to mountain for various reasons. Some of them go to Gosai Kunda or Kailas Mansarovar for religious purpose, and some of them are trekkers and climbers and they go to Everest or Kilimanjaro, and some people are skiers who goes to Alps, and there are tourists who go to Ladakh and Labaj, and there are various people who go to high altitude for working purpose, like miners. They go to high altitude sites in South Americas, and there are various military personnel who are deployed to high altitude locations. And we should know that high altitude illness is likely to occur above 2,500 meter, but has been documented even at 1,500 to 2,500 meter altitude above the sea level. And there are various spectrum of high altitude illness, which range from acute mountain sickness or high altitude cerebral edema or HACE, or people can even develop high altitude pulmonary edema or HAPE, or there are various other altitude related problems, and we'll be discussing a little about each and every of them. First, talking about the physiological changes that occurs in the body when a person goes to the higher altitude. Initially, when a person or people go to high altitude, there will be decreased oxygen concentration in the atmosphere, which leads to decrease in barometric pressure that results in decreased partial pressure of the oxygen in the inspired gas in the lungs, which leads to hypoxia. And the hypoxia is received by all the chemoreceptors of our body, which leads to the activation of the central respiratory systems, which leads to the hyperventilation. And because of the hyperventilation, it will cause respiratory alkalosis and dehydration, and which leads to consequent periodic breathing and hypoxemia. And this, during all this early phase of acclimatization, renal suppression of the carbonic anhydrase and excretion of dilute alkaline urine compact alkalosis, and this tends to bring the pH of the blood to normal. And this happens initially in the beginning period of time. Over a large period of time, what other physiological changes occurs includes there will be increase in sympathetic tone, there will be increase in erythropoietin level, hence leading to increased hemoglobin level and red blood cell mass. Hence, it will easily combat hypoxemia, and there will be increase in tissue capillary density and mitochondrial numbers, which leads to increase in level of 2,3-bisphosphoglycerate, enhancing oxygen utilization. This is all what happens in the person who has got healthy physiological status. But if a person goes to high altitude without giving proper time to acclimatize to the body, or if a person has got some defect in the body that leads to the disturbance in the physiological changes, then the person will present with the acute mountain sickness or any other form of the high altitude illness. Now, first, we will be discussing about the acute mountain sickness. You people should know that acute mountain sickness is a clinical diagnosis in which the person will have got a neurological syndrome, which is very non-specific, like the patient will develop headache, nausea, fatigue, and dizziness. And there will be no any physical finding when you do the clinical examination. And you should know that acute mountain sickness usually develops 6 to 12 hours after ascent to the high altitude. And there are various risk factors for the development of altitude illness, and which includes the rate of the ascent and a prior history of the high altitude illness. Now, moving on to the pathophysiology of acute mountain sickness. It is a hyperbaric hypoxia that is the main trigger for the altitude sickness, altitude illness, and the others include raised intracranial pressure, increased sympathetic activity, relative hyperventilation, fluid retention and redistribution, and impaired gas exchange. And now, how can we prevent this acute mountain sickness? The one and only thing about the prevention is the gradual ascent with adequate time for acclimatization. And even though there may be individual variation in the rate of acclimatization, a conservative approach would be a graded ascent of 300 meter or less than 300 meter from the previous day's sleeping altitude above the 3000 meter. And the other thing that we can do is use of acetazolamide at the dose of 125 or 250 milligram twice a day. It should be administered for 1 day before ascent and continued for 2 or 3 more days. The other drugs that can be used are dexamethasone, and there are various over-the-counter drugs like Soroche pills, which contain aspirin, caffeine, and acetaminophen, which are sold over the counter and which is very popular among the climbers. And how, if a person develop the acute mountain sickness, how to treat it? Initially, as it is a clinical diagnosis, clinically you should find out if the disease is mild or severe. And for the treatment of the mild acute mountain sickness, rest alone with analgesic use may be adequate. And if you want descent and the use of acetaminophen, if available, and oxygen are sufficient to treat most of the cases of the moderate acute mountain sickness. Even a minor descent about 400 to 500 meter may be adequate for symptom relief. And for moderate acute mountain syndrome or early HACE, dexamethasone is highly effective. As I've told you, you clinically find out whether it is mild or moderate. In case of mild, discontinuation of the ascent with treatment with acetazolamide or descent is totally useful, and you don't need much more treatment. But in case of moderate disease, you should immediately do the descent for worsening symptoms, and you can use the low flow oxygen if available, and you should treat with acetazolamide and or dexamethasone with hyperbaric oxygen therapy. Hyperbaric therapy if descent cannot be done. Now moving on to high altitude cerebral edema. It's an encephalopathy whose hallmarks are ataxia and altered consciousness with diffuse cerebral involvement, but it's generally without local neurological deficits, and usually the patient usually have papilledema and retinal hemorrhage. And now moving on to the pathophysiology of HACE. Usually there is a MRI study have suggested that the vasogenic or interstitial cerebral edema is a component of the pathophysiology of HACE. And there is impaired cerebral autoregulation in the presence of hypoxic cerebral vasodilatation and altered permeability of the blood-brain barrier due to the hypoxia-induced chemical mediators like histamine, arachidonic acid, and the BGF may all contribute to the brain edema. And the other factors include the release of the calcium-mediated nitric oxide and neuronally mediated adenosine, which may promote cerebral vasodilatation. And there is also a venous outflow obstruction resulting in the increased brain capillary pressure. It also plays a important role in the development of the high-altitude cerebral edema. Now moving on to the treatment, the first treatment is the immediate descent or evacuation. However, if there is a problem in descent, if it is night time or if the weather is harsh and you can't do the immediate descent, then hyperbaric therapy can be of great help. It is given by using a hyperbaric bag. It is a cylindrical portable, which is just less than 7 kg nylon bag, and which has got one-way valve which prevent the carbon dioxide buildup. And in this, this simulates almost like a descent. What you have to do is you put the patient inside the bag, and you have to continuously inflate with a foot pedal. If the patient is kept inside this bag and the treatment is done like that, then there is no need of administration of the oxygen. And the other treatment include, as I told you, administration of the oxygen about 2 to 4 liters per minute, and the treatment with dexamethasone should also be done. Now moving on to high altitude pulmonary edema, or HAPE. This develops within 2 to 4 days after arrival at the high altitude, and it rarely occurs after more than 4 or 5 days because of the acclimatization at the same altitude. And because of the remodeling and the adaptation that render the pulmonary vasculature less susceptible to the effect of hypoxia. And there are various risk factors for the person to develop HAPE, which includes a rapid rate of ascent or a history of HAPE or a respiratory tract infection and a cold environmental temperature. In the patient who develop high altitude pulmonary edema, you should always look for a echocardiogram, and so that we could see if there is any other cardiopulmonary abnormality which predispose the patient to have a HAPE. Now, moving on to the pathophysiology, high altitude pulmonary edema is a non-cardiogenic pulmonary edema with normal pulmonary artery waist pressure. So it's characterized by patchy pulmonary hypoxic vasoconstriction that leads to overperfusion in some areas. And this abnormality leads in turn to increased pulmonary capillary pressure and capillary stress failure. And there is also some endothelial dysfunction due to hypoxia, which plays a role by impairing the release of the nitric oxide, which is an endothelium-derived vasodilator. And even the exercise and cold lead to increased pulmonary intravascular pressure and may predispose to the HAPE. In addition, hypoxia triggered increase in sympathetic drive may lead to pulmonary vasoconstriction, extravasation into the alveoli from the pulmonary capillaries. And other proposed mechanism for the HAPE is impaired transepithelial clearance of sodium and water from the alveoli. And now moving on to the clinical features, how to find out if the patient has developed HAPE or not. The initial manifestation is the reduction in exercise tolerance greater than the expected at the given altitude. And though cough is very common in the person who has gone into high altitude, you should find out if that cough is just a minor symptom or it is due to high altitude pulmonary edema. In cases of the high altitude pulmonary edema, cough is usually productive, which is blood tints sputum, and there will be other associated features like tachypnea and tachycardia, even a trace. And there, when you do auscultation, you may find out there may be some crackles. And if you order a chest X-ray, you could find out patchy or localized opacities or a strict interstitial edema. And usually all this finding of the chest X-ray can go away almost completely in 2 days with descent and supplemental oxygen. And if you do echocardiogram, you may reveal a right ventricular strain or even hypertrophy. And if hypoxia and respiratory alkalosis are consistently present, unless the patient is taking acetazolamide, in which case metabolic acidosis may supervene. If a person has a previous history of high altitude pulmonary edema, or a person has got some work or because of some urgency but a person has to do the ascent to high altitude without giving proper time to acclimatization, then we can even prevent the person from developing the high altitude pulmonary edema by using of the various drugs like nifedipine or inhalation medicine like salmeterol, because it helps in clearance of the alveoli, or you can even give the tadalafil or dexamethasone. Now, if a patient develops high altitude, despite all your efforts, and if the patient develop high altitude pulmonary edema, we have to do the immediate treatment, and the treatment is immediate descent or evacuation. And as already discussed, if there is no availability of the descent, or if the weather is very harsh and it is night time, then you can even give the hyperbaric therapy if descent is not possible. And the other treatment modalities include minimization of exertion, and the patient must be kept warm, and you should administer oxygen to the patient about 4 to 6 liters per minute to bring oxygen saturation to more than 90%. And with that, you can give the adjunctive therapy with nifedipine 30 milligram extended release 12 hourly. And now moving on to the other high altitude problems like sleep impairment. And it's a common adverse reaction to high altitude, and it includes there is increase in periodic breathing, and there is change in sleep architecture with increased time in lighter sleep stages and change in rapid eye movement sleep. And the treatment for this, for prevention of this, a patient can take acetazolamide 125 milligram before bedtime, and this decreases hypoxemic episodes and alleviates sleeping disruption caused by excessive periodic breathing. And the other common problem that a person can get while climbing to the higher altitude is gastrointestinal issues. Usually there will be an increase in gastric and duodenal bleeding, and there will be abdominal bloating and distension, as well as excessive flatus expulsion. However, you should know that diarrhea is not a common feature of high altitude sickness, and if it is present, you should always look if there is any bacterial giardial parasite, as it is often very common disease that occurs in the mountaineers. and prompt treatment with fluids and empirical antibiotics would be done. And hemorrhoids are common on high altitude trekkers, and treatment includes hot soaks, application of hydrocortisone ointment, and measures to avoid constipation. And the next very common illness that occurs in the high altitude people is the high altitude cough. However, it's very common in some of the patient. It could be very debilitating, as it's sometimes so severe enough that it even causes rib fracture, especially in the case when the person is above the 5,000 meter, and it can be due to inspiration of the cold air or hypoxia, and even exercise can precipitate cough at high altitude. And for this, the treatment done is the combination of inhaled medication of the fluticasone and the salmeterol, that is the combination of the steroid and the beta agonist, and this is the treatment of choice for the high altitude cough. And many of the trekkers find it useful to wear balaclava to trap some moisture and heat so that they won't develop any cough. And cough usually resolves totally open descent. And the next a very commonly encountered problem in the people who go to high altitude is the psychiatric problem or psychological problems. Usually, people usually have present with delirium. Delirium characterized by a sudden change in mental status, a short attention span, disorganized thinking, and an agitated state during the period of confusion has all been well described in mountain climbers and trekkers without a prior history of similar episode. And in addition, anxiety attacks often triggered at night by excessive periodic breathing are well documented. Now, moving on to the chronic mountain sickness and high altitude pulmonary hypertension in Highlanders. Chronic mountain sickness or Monge's disease is a disease in Highlanders that is characterized by excessive erythrocytosis with moderate to severe pulmonary hypertension leading to poor pulmonary. And if the such patient migrate to low altitude, it results in resolution of the chronic mountain illness. And the other treatment option include venesection and acetazolamide. High altitude pulmonary hypertension is also a subacute disease of long-term high altitude resident. However, unlike Monge's disease, this syndrome is characterized primarily by pulmonary hypertension, but not erythrocytosis leading to heart failure. And the only treatment of this disease is descent to a lower altitude is curative. This is all for today. Thank you.